Good day, everybody. My name is Fons van Berg. I'm a resident in training at the Department of Medical Microbiology and Infection Prevention at the Amsterdam UMC location AMC in the Netherlands. And today I will be presenting the lecture I gave at the SISE convention in Dublin in May 2025. And I appreciate the invitation to speak, of course, about the host microbiota interactions in surgical infections. And I will be trying to answer the following question. Are we ready for clinical application of microbiome diagnostics and interventions in surgical diseases? I have no disclosures. So these are the topics that I will be talking about today. After the introduction, I will first talk about the host microbiome interactions regarding anastomotic leakage and surgical site infections. Then about acute pancreatitis, which is the focus of my research done with the Dutch Pancreatitis Study Group. And last about the clinical applications of microbiome-based diagnostics and interventions in general. So first, a little bit about the history of microbiome research. It goes down to the 4th century, and according to Chinese literature, people with diarrhea were already treated with something they called yellow soup, which is a kind of an ancient version of a fecal transplant. Well, the Dutch scientist Van Leeuwenhoek, who developed the first microscope, already saw creatures in the feces in the 16th century, which he called animalcules. And the germ theory of communicable disease was first postulated in 1861, which significantly increased the interest in microbiology in general, including a study in the microbiome. So we started treating patients with fecal transplants for C. diff in 1958. And a real game changer for microbiome research was the development of next generation sequencing, which allowed to sequence the whole human microbiome for the first time. So what does the term microbiome actually mean? So in modern literature, often the Nobel Prize winner Joshua Lederberg supposedly would come up with this definition in 2001. However, the first definition was already circulating in 1988. And the nice thing about this definition is that it doesn't only refer to the microorganisms themselves, but also their habitat and theater of activity, which is a really a newest way to look at it. And this is more a visual representation of this. So the microbiome consists of the microbiota, including the theater of activity, which are the proteins, the lipids, DNA, RNA in this niche, including the environmental conditions and the microbial metabolites. So while we mainly focus on bacteria during this talk, because most studies were done with bacteria, it's good to realize that the intestinal microbiota is comprised of more than just bacteria, also fungi, viruses, and in many parts of the world, also parasites. And although the load of viruses is much higher compared to bacteria, only a few percent of the microbiome studies were actually done on the virome. So the healthy bacterial gut microbiome consists for the largest part of obligate anaerobes that coexist with the host and exert numerous important functions, such as in the immune regulation and production of metabolites. And it's good to realize that the mucosa of the gut is hypoxic, which allows anaerobes to grow there. And then again, the gut microbiota supports this by producing metabolites, supports this oxygen gradient by stabilizing this. So for some decades, we are trying to establish a core human microbiota that is important for humans. But however, their individual variation is substantial. And this recent paper in Cell combined 11 case control data sets spanning 7 diseases and a dietary clinical trial. And what they found was 2 signatures, one associated with health and one associated with disease. And when they took the signatures, they were able to in separate data sets, accurately distinguish patients from healthy controls and responders from non-responders to therapy. So when we zoom into this healthy core microbiota, we see that all of those bacteria are in the phylum of the Firmicutes, and health-associated species such as Faecalibacterium prausnitzii they are very prevalent amongst them. So there are several tools to actually characterize the microbiome. One of the methods is culturomics, which is a culture-based method. However, many gut bacteria are not so easy to culture, and you cannot reliably establish relative abundances of species. You can do this with the metagenomics, which is a DNA-based method. But then again, it does not prove that the DNA sequences that you find are really from live bacteria. So then you can also study the microbiome with metabolomics to measure metabolites that are produced by the microbiota. It can give some insight in the functional properties of the microbiota, but it doesn't inform on the abundance of the microbiota. So in an ideal situations, you would combine all of these methods to gain a real insight in the machinery of the microbiome. So now let's examine how the microbiome affects anastomotic leakage. So what are actually the causes? Well, many surgeons will tell you it's due to a technical error, especially if somebody else operated. Otherwise, we can always blame the patient for their lifestyle or the genetics or the anesthesiologist. And the microbiome as a cause of anastomotic leakage was largely overlooked until a decade ago or so. So the first questions that we need to ask ourselves is which bacteria are actually driving anastomotic leakage. Well, this Dutch study, they did a 16S applicant analysis study on the stapler donuts from colorectal surgery patients, and they found associations mainly with anaerobic bacteria, which you can see here in blue. And many of them are actually health-associated bacteria that makes you wonder if these are really causative bacteria. So a recent meta-analysis that also included this study shows the same pattern. There were mostly associations with anaerobic bacteria, and many of the findings were not replicated in other studies. And the only really common denominator was bacteria from the Lactobacillus family, which are consistently associated with anastomotic leakage in at least 3 studies. So another approach to study the microbiota in anastomotic leakage is transplantation of a human phenotype to mice. So in this nice paper, the authors gave fecal transplants derived from patients that developed an anastomotic leak, and they subjected those mice to a colorectal surgery. And then they noticed that the mice that received FMT, so fecal transplant from patients, they also more often developed a leak. So then they associated their sequencing data with clinical and biochemical analysis in their mice model, and they pinpointed 2 bacteria, Elastipus ontodonci and Parabacteroides zygotsteini, as possible disease modulators. So both bacteria are again obligate anaerobes, and none of them were previously associated with anastomotic leakage in observational studies. So next they administered those bacteria to mice, subjected them to colorectal surgery, and they really confirmed that these bacteria contributed to anastomotic leakage in their experimental model. So Dr. John Alverdy and his lab members did pioneering work in the field of anastomotic leakage in the microbiome. And they saw in their mouse model that following colorectal surgery, mostly E. coli and enterococci, which are both aerobic pathogens, were proliferating at the site of the anastomosis. So to conclude, aerobic bacteria such as enterococci and E. coli, they bloom at the anastomotic site, but they are not clearly associated with anastomotic leakage in clinical studies. However, anaerobes from the Lactobacillus family seem to be associated. And many of the found associations were not replicable in other studies. So this makes you wonder if this might be the explanation why SDD, selective decontamination of the digestive tract, does not reduce anastomotic leakage in a clinical trial. SDD is really focused on aerobic gram-negative bacteria and fungi, and supposedly spares anaerobes. And this Dutch randomized control trial investigated this and found that SDD prevents post-op infections, but it does not reduce anastomotic leakage. And they also did a molecular analysis on feces, and they confirmed that STD mostly impacted aerobic bacteria from the proteobacteria group, such as E. coli and Klebsiella and so on. So then the Alverdy lab started investigating Enterococcus faecalis, and they used a devascularization model of anastomotic leakage. And they showed that Enterococcus faecalis reduced collagen formation, also activates MMP9, and that both of them are necessary to cause a leak in their model. So then they did subsequent studies, and they showed that Enterococcus faecalis interacts with the fibrinolytic system, that also influences the tissue healing, and that inhibiting this system with tranexamic acid reduces anastomotic leakage. So not only Enterococcus interacts with this target, the previously identified bacteria associated with anastomotic leakage, L-stipes and Parabacteroides, also target these downstream targets of colonic tissue healing. So regarding the host microbiota mechanism in anastomotic leakage, Enterococcus faecalis, but also anaerobes, seem to impact tissue healing. And anastomotic leakage interacts with the fibrinolytic system and collagen degradation. So then we are moving from anastomotic leakage to another great problem in clinical practice, which are the surgical site infections. So for clean surgery, most surgeons assume that infections occur due to exogenous bacterial source, and a lot of effort is done to keep bacteria out of the sterile field and to decontaminate the skin before surgery. And during clean, contaminated, and contaminated surgery, and during abdominal sepsis, the source is more often endogenous from the gastrointestinal microbiota. So this really nice recent study published in Science Translational Medicine showed that the composition of the skin microbiota is associated with the anatomic location of the surgical incision in patients undergoing spinal fusion and surgery. And enteric pathogens such as the anaerobes and E. coli, they are more prevalent towards the sacral spine, which are here marked in red. And the skin microbes here in light blue, they are more prevalent towards the cervical spine, which is probably not a real surprise. So they found comparable results in the wound cultures, and they found more skin-derived pathogens in cranial wounds, more enteric pathogens towards the sacral spine. And then they compared these strains with next-generation sequencing and found that 86% of the wound infection strains were already present in the skin microbiota prior to surgery. And they excluded a possibility of a common source of infection by comparing the strains with other strains they found in the hospital. And also they found that the majority of pathogens were resistant to the perioperative prophylaxis that was given to those patients. So there's important limitation to this very interesting study. So it's very important to rule out contamination of the wound cultures to determine if it's really a causative pathogen. So ideally, aseptic techniques should be used to obtain multiple biopsies and using different instruments for each biopsy. So this is already customary in prosthetic joint surgery for prosthetic joint infections, where they obtain 3 to 5 deep biopsies during surgery. And this is especially important for implant surgery because there is a really broad range of possible microorganisms that causes infection. However, despite those limitations, this study shows the potential of adjusting your perioperative prophylaxis to the anatomical location of the incision and the skin microbiota present. So another source of wound infections that is often overlooked is bacterial translocation from the gut. And a really interesting concept is the Trojan horse theory. When patients get colonized with an opportunistic pathogen and encounter a neutrophil, it can get engulfed by a neutrophil and stay alive. Then it travels to a susceptible tissue, such as a fresh wound bed, and there it finds the ideal niche to proliferate and cause infection. So this proof of concept study in mice showed this possibility, where they made an ischemic wound in the rectus muscle of a mouse, and then they give MRSA orally. And then they noticed that these mice developed abscesses without the presence of bacteremia, so really excluded a hematologist's route of infection. And they also administered MRSA intravenously and topically, and surprisingly, those mice did not develop any abscesses. So regarding surgical site infections, both exogenous and endogenous routes of infection are possible, including through neutrophil migration, and those should be considered when thinking about these kind of infections. And also microbiome analysis may be used in the future, for example, to personalize antibiotic prophylaxis. So the next part is about acute pancreatitis, which is the focus of our own current research projects. So acute pancreatitis usually starts with a trigger, most of the times gallstones or alcohol use. And this pancreatic inflammation then causes systemic inflammation, which then in turn damages the intestinal barrier. And during the early disease course, bacteria and toxins translocate, and they cause even more systemic inflammation, which then leads to organ failure in some patients. And during the late phase of the disease, so after approximately 2 weeks of hospital admission, those bacteria can translocate and then cause secondary infection of pancreatic necrosis. So many trials were done in the past decades to intervene in this process. For example, probiotics were given to restore intestinal balance. Prophylactic antibiotics were administered to prevent infectious complications, and immunomodulation was tried to dampen the systemic inflammation. But all of these trials failed until so far, and probably because we have a lack of mechanistic insight in these complex processes, and we probably need a more targeted approach. So there's one exemption, that is selective decontamination of the digestive tract to prevent mortality in affected necrosis. And there was actually a Dutch trial done in 1995, and they randomized patients with severe pancreatitis between SDD and standard of care. And they saw that prophylactic SDD included with a few days of intravenous cefotaxime significantly reduced mortality. And they also did a post-hoc analysis of this study, and they showed that it were mainly the gram-negative pancreatic infections that were being reduced with SDD. However, despite those convincing results, SDD was never implemented in routine pancreatitis care, and it might be because there were some methodological issues. For example, the study was underpowered. Some of the definitions, including the definition of infected necrosis, were not described. And therefore, this study was never recommended in the international guidelines. And also, sadly, there were no follow-up trials conducted. So recently, there was a large microbiome study published by a German group in Gut, and they split their group of acute pancreatitis patients in a severe and a non-severe group based on the presence of organ failure and the necessity for a drainage procedure. And then they matched those patients in a 2-to-1 ratio. And what they found, that was a 16 species classifier combined with the presence of SEERS, and that could accurately predict at baseline which patients would develop severe disease with an area under the curve of 87%. And they noticed that when looking at this classifier, that many of the species that were in this classifier were also capable of producing short-chain fatty acid. And the authors speculated that short-chain fatty acids may actually predispose for the development of severe complications. So why are short-chain fatty acids potentially important in this disease? Well, they are the product of metabolization of fibers by the gut microbiota, and it mainly composes of 3 short-chain fatty acids, acetate, butyrate, and propionate. And especially butyrate is associated with health through HDAC inhibition, and it's also the main metabolic substrate for colonocytes, and therefore also for the maintenance of the gut barrier. And it also have immunomodulatory effects. So our group also dived into this, and therefore we executed the PUMA study, and the main aim was to dive further into the host microbiota interactions with the aim to develop novel therapies. And the second aim was to investigate if microbiome monitoring could be used to predict infectious complications during necrotizing pancreatitis. So in this study in total, we include almost 300 patients with acute pancreatitis in 20 hospitals. And we collected rectal swabs and saliva and then profiled the microbiota with the 16S amplicon sequencing. And then we specifically looked at a panel of butyrate-producing bacteria and made subgroups based on more or less than 14 days alive and out of hospital within a 30-day follow-up. And when looking at the level of butyrate-producing bacteria, we saw that butyrate producers were lower in the patients that were hospitalized longer. And we saw this pattern before, actually, in a study that we published in 2021, where we saw that butyrate producers were decreased in patients with acute pancreatitis compared to healthy control patients. So in an attempt to establish a causative link, we developed a mouse model of necrotizing pancreatitis, and we administered those mice a high-fat Western type diet to change their microbiome to a more pathogenic state with reduced commensal health-associated bacteria. And we saw in this model that the mortality was significantly higher in mice that were given this high-fat diet compared to mice on a regular chow diet. And we also saw more pancreatic and systemic infections in those mice and lower levels of butyrate in the ileal content. So then next, we use this model to supplement mice with butyrate, either systemically or orally by supplementing their drinking water. And we observed a really dramatic decrease of mortality in those mice receiving butyrate, accompanied by lower endotoxin levels. So to conclude, short-chain fatty acids are likely involved in disease severity, although the specific effects of each short-chain fatty acid and the direction of action remains under investigation. But for butyrate, most evidence points towards a beneficial effect. So to investigate the clinical utility, we are currently enrolling patients in a proof of concept trial called the Berg trial. And there we are administering a high dose of terbutarin or placebo to patients with acute pancreatitis. And terbutarin is hydrolyzed in the gut, and then it gradually releases butyrate along the length of the gastrointestinal tract. And the primary endpoint is serum endotoxin after 3 days of treatment, but also a range of other targets, including the host response, are under investigation. And currently, we are almost at half of the total inclusion. So there are more important intestinal metabolites beyond the short-chain fatty acids, such as the secondary bile salts. They're also associated with health and produced by the intestinal microbes from primary bile salts. And they have multiple known effects, such as antimicrobial protein production, maintenance of the mucosal barrier function, anti-inflammatory mucosal response, and colonization resistance. Another interesting group of metabolites are the tryptophan metabolites. There are 3 main metabolic pathways, of which the indole pathway is heavily regulated by the intestinal microbiota. And these indoles are important in regulating mucosal integrity and the mucosal immune response. And our group has also has plans to investigate those mechanisms. So the second main aim of the PUMA study was to see if the microbiota could be used to monitor patients for infections, especially since the most dreaded infectious complication, infected necrosis, usually occurs after 2 to 4 weeks of hospital admission. So we serially collected samples from patients with the predicted severe acute pancreatitis, and in total, of those 300 patients included, 57 patients developed necrotizing pancreatitis, and 20 of those 57 patients developed infected necrosis. And when we look at the baseline characteristics, comparing the steroid and infected necrosis subgroup, we noticed that those groups were equal in terms of age, sex, and comorbidity. However, we noticed that there were more alcoholic etiology in the infected subgroup, and also the initial Apache 2 score was higher, and those patients also had more extrapancreatic infections. So when we look at the alpha diversity, which is the diversity of bacteria within a sample, we saw that it steadily declines throughout hospital admission, but we didn't see real differences between the sterile and infected subgroup. Then the beta diversity, which means the diversity between groups of samples, we saw that especially in the salivary microbiome, there was a really distinct pattern in the microbiome composition. So surprisingly, our untargeted differential abundance analysis did not identify any taxa that were associated with infected necrosis. It might be due to the relatively small sample size of this study. So next we looked at groups of bacteria of interest that are also commonly found in affected necrosis samples. And we noticed that Enterococcus was more often detected in saliva of patients with affected necrosis compared to patients with sterile necrosis. And this became the focus of our subsequent analysis. And then we used a Cox proportional hazards model with the microbiota parameters as time-dependent predictors. And we saw that Enterococcus colonization in rectal swabs and the presence of Enterococcus in saliva samples were both associated with infection. And even after adjusting for imported confounders, including the initial Apache 2 score, these associations remained robust. And what is really clinically important is that we saw this first positive sample, either in saliva or rectal, at a median of 23 days before infected necrosis diagnosis. So we did a sensitivity analysis to look at different thresholds for Enterococcus relative abundance. And we noticed that across multiple thresholds, Enterococcus in rectal samples was associated with infected necrosis, which rules out the overfitting of the model. And in saliva, we saw that the presence, but also the continuous variable, were both associated with infected necrosis. And we observed the same pattern when we adjusted for early infections instead of Apache 2 scores. And here are two exemplary patients. Both patients were administered antibiotics early on in the disease course, after which Enterococcus bloomed. And both of these patients developed an infection with Enterococcus faecium. So then we looked at which clinical factors are associated with infected necrosis, and we noticed that early antibiotic treatment, which means antibiotic administration in the first week of admission, was associated with infected necrosis. So then we were wondering which clinical factors were associated with Enterococcus colonization. And we found that also that early antibiotic treatment made patients at risk for Enterococcus colonization. So finally, we looked at the effects of early antibiotics on the microbiota composition, and we found again that in saliva samples, it had the largest effect on the microbiota composition, and also it had an effect on the level of butyrate-producing bacteria in the patients administered early antibiotics. So we finally concluded that Enterococcus colonization is associated with infected necrosis, and it may be caused by early antibiotics. However, there are some important limitations to the studies. Mainly because this is an associative study. It's not designed to establish a causative link. Species level determination was not possible due to the use technique, and also functional analysis were not possible. And what is important for future clinical application, this sequencing pipeline is not yet suitable to produce fast results. So the last part is about the readiness for clinical application of microbiome diagnostics. So to really answering the question from the beginning of this talk, is the field ready for clinical application? Well, I'm afraid not yet. Of course, everybody wants to show something novel and publishes association studies, but there's a real need for diagnostic accuracy studies, clinical trials, and implementation studies to really have an impact on daily patient care. And especially the implementation of a microbiome diagnostic pipeline is very challenging because we need wet and dry lab pipelines. We need to standardize our reporting of microbiome diagnostics. We need a multidisciplinary consultation structure, and we need to think about uh, how we are producing those results and give a corresponding advice and how we are communicating this back to the clinicians. And also the responsibilities of each stakeholder in this process need to be clearly defined. So recently, an international group of experts already thinking ahead about how microbiome testing should be performed, when it should be performed, and how it should be reported. So several working groups were formed, and each were focusing on a different aspect of microbiome testing, such as procedural steps before testing, how to do the microbiome analysis itself, and how to report it back. And especially the recommendations about the relevance of microbiome testing in clinical practice are really sobering because they conclude that there's currently insufficient evidence to widely recommend the routine use of microbiome testing in clinical practice. So we have some work to do. So what are the specific next challenges for the diseases that I talked about today? Well, I think for anastomotic leakage, the field needs to move away from association studies to more diagnostic and implementation studies. I think there is enough evidence to do a trial with tranexamic acid as routine prophylaxis for patients undergoing colorectal surgery. And for surgical site infections, we really need validation studies to investigate the diagnostic value of microbiome and anatomic location-based prophylaxis. So for the acute pancreatitis studies that we are currently studying, there are a few ongoing studies. We are doing mechanistic studies to further investigate microbiota host interactions in patient samples and also in animal models. We are looking at developing a point of care test to monitor the microbiome and also start looking at the host response. We are already doing the PARROT trial to look at butyrate supplementation in acute pancreatitis. And we are planning to execute a prophylactic SAD trial, which is called the Piranha trial. So last of all, I want to thank everybody involved in the studies, and thank you all for your attention today.